Hello, I'm Dr. Rayhan Falari, and I welcome you again. This time around, we'll be going into gross anatomy. And during this presentation, you will be learning more about the gross anatomy of the shoulder and back region, which are very fundamental regions of the human body. So let's dive in. By the end of this class, it's expected that you will understand better the anatomy and the functions of both of these regions, that's the shoulder and the back, and identify major muscles, nerves, and blood vessels in both of these areas, and be able to recognize some clinical correlations that are related to both of these regions. So let's go in further. So as an overview, right here is the shoulder, is showing the back region. I'm trying to get my pointer. Yeah, I have the back region here uh, from the posterior view, and then you have the shoulder region on this end. So the shoulder region is that part that connects the upper limb. Right now, you don't refer to it as just the hand. So the entirety of the upper limb starts from the shoulder region down to the arm, the forearm, and then much lower. So the shoulder region is what connects the upper limb to the torso, which is um, the, the axial skeleton, if you may. So the shoulder region connects the upper limb to the torso, allowing a wide range of motion that are critical for daily activities, including that which I am doing now, which because I'm toggling around my computer to give this lecture. And you're probably holding your device, listening to this because you're making use of your upper limb, which is connected to the torso through the shoulder. So it allows for complex movement. The back, on the other hand, supports posture regardless of the posture, and it enables movement of the torso and protects the spinal cord within the vertebral column. So the shoulder girdle, unlike we discussed during the physical class, the shoulder girdle is a combination of both shoulder regions. So it's referred to as a girdle when you consider both shoulders together, and each region consists of the clavicle and the scapula. You can readily see the scapula behind here, and then the clavicle is anterior placed here. We'll see more of this in subsequent slides. So the vertebral column consists of 33 vertebrae across the cervical region, the thoracic region, the lumbar region, the sacral region, and the coccygeal region. Five main vertebral regions that make up the human body. And you will appreciate here the vertebrae as they are placed arranged on top of one another, and each vertebra from the superior view is appreciated here. And we'll go into further details about these in subsequent slides. So we identify three major joints in the shoulder region, particularly the glenohumeral joint, which is that part between the glenoid cavity and the head of the humerus right here. So here is the glenohumeral joint, and then you have the acromioclavicular joint, and that's between the acromion of the scapula and the lateral end of the clavicle, as you already appreciated during your osteology. And we also have the sternoclavicular joint, like the name suggests, between the sternum, that's otherwise known as the breastbone, and the clavicle, again, the medial end of the clavicle this time. And particularly, this is a joint between the manubrial part of the sternum. So the vertebral column also has joints which range from the intervertebral disc region as well as the facet joints, which enable flexibility and the stability in the spine. So these are what enable the vertebra to be able to accommodate the movement that we know. And the shoulder muscles also facilitate the arm movement and the stability of the shoulder. We also have muscles in the back region, which support the posture because the skeleton will not be able to move without muscles. So the muscles support the posture and protect the spine and also allow for the trunk movement. So let's dive deeper into the anatomy of the shoulder region. The bones of the shoulder includes the clavicle, which is otherwise known as the collarbone, and you see it here. So it's an S-shaped bone that is acting as a strut between the sternum, which is detached here, and the scapula. So it serves as a strut between them, and it serves as an attachment site for muscles and ligaments, thereby giving an aid to shoulder movement and providing support to the upper limb. The scapula is another bone of the shoulder joint, which is right here, and it goes all in this extent. It is a flat triangular bone on the posterior thoracic wall, and it has key landmarks as well, including the acromion right here, the coracoid process, and then you have the glenoid cavity that hosts the glenoid uh, head of the humerus, and then you have the scapular spine on the back. It has other features as well. The humerus, the third major bone that contributes to the formation of the shoulder bone, the shoulder joint, is also known as the arm bone or the upper arm bone. But when you just say arm, it typically refers to the humerus. But when you mean the forearm, then that is referring to the region where you have the fibula and the radius. So here the humerus is that part that is proximal, that articulates proximally with the scapula at the glenoid cavity, thereby forming the glenohumeral joint. Ulnar and radius event. So the glenohumeral joint is a multi-axial ball and socket joint which lies between the humeral head and the glenoid cavity. So the glenohumeral joint is a multi-axial ball and socket joint that you have between the humeral head and the glenoid cavity, and it provides a wide range of movement, but it relies on the surrounding muscles for stability. And of these muscles that help with the stability, we have the rotator cuff, which we'll come to in a minute. We also have the acromioclavicular joint, like the name suggests, between the acromion of the scapula and the lateral end of the clavicle, and it allows scapular movement and is stabilized by strong ligaments, which we'll mention shortly. We also have the sternoclavicular joint, as mentioned earlier, which is a saddle type joint. It occurs between the clavicle and the sternum, and it's only bony connection between the axial skeleton and the upper limb. The axial skeleton, like mentioned earlier, is the head uh, down to the neck, and the thorax, the back, and the pelvis. Okay, that's so this way the sternoclavicular joint helps to allow rotation, even though it's quite limited, and movement of the clavicle. Now, these are important shoulder joint movements. You have, starting from here, the flexion. Usually, if you were to be at the elbow, we easily will understand that in the anatomical position, the flexion will be towards the movement in the anterior direction, while extension will be in the posterior direction. But flexion at the shoulder joint now is also in the anterior direction, but then it takes the entirety of the upper limb, right? So it moves, when it goes in this direction, it's flexion. As you can see, this arrow. So when you move the entire upper limb at the shoulder joint in the anterior direction upwards, that is flexion. And if you move it downward or posteriorly in this direction, that is extension. We also have the external and internal rotation. For these, first of all, the shoulder joint can be abducted. Once the shoulder joint is abducted, or the upper arm is abducted, then external rotation and internal rotation will be in this direction that is shown here. So it's a movement that is happening at the shoulder region as well. Then we can have the horizontal flexion and horizontal extension, which rather than being a movement upward and downward as previously shown, it's now going to be in the lateral versus medial direction. So when you move anteriorly, laterally, that will be horizontal flexion, and when you move in the opposite direction, which will be towards the posterior from the midline on the lateral plane, that will be the horizontal extension. Abduction is taking the upper limb away from the side of the body. That's abduction. So you'll be abducting the entire upper limb, and then at the shoulder joint, and then when you bring that back in the opposite direction, there will be adduction. Circumduction is the kind of movement when you're skipping a rope. So it's called circumduction. So it's a combination of a number of these other movements that have been mentioned. So internal rotation and external rotation at the shoulder joint will be in this direction. So here is the external rotation, all right, where the so it's similar to what was illustrated here, where the upper arm remains by the side, and then you take the forearm now, which if you like to call that the lower arm. So you then take that in the lateral plane and extend it outward, so that will produce an external rotation at the shoulder joint. Okay, and if you bring that forward in this direction, that will produce internal rotation, all happening at the shoulder joint. Okay, so the muscles of the shoulder now. There are 6 main muscles that surround the shoulder joint, and we have amongst them a group of 4 muscles known as the rotator cuff muscles. These refer particularly to the subscapularis, the infraspinatus, the teres minor, and the supraspinatus. These 4 make up the rotator cuff muscles, and a cuff is what I've put here to remind us what the shape is. So they are so called because of how they form a cuff around the shoulder. So making this kind of wipe, this kind of wrap around the shoulder. So remember the cuff with the links, the cuff links. So here, making this kind of wrap around the shoulder is why they are called the rotator cuff, and we'll understand these muscles in a little bit. So apart from these 4 muscles that make up the rotator cuff, we still have the deltoid muscle and the teres major. So here are the 4 rotator cuff muscles listed: the supraspinatus, the infraspinatus, the subscapularis, and the teres minor muscle. We'll come back to their function in a minute. So generally, these muscles they function to move and stabilize the shoulder joint, and generally as well, the muscles run between the scapula and the humerus. So they are able to move the shoulder joints because of their origin coming from the scapula and their insertion into the humerus. So starting with the subscapularis muscle, like the name suggests, subscapularis. So it's more like underneath the scapula, and you'll appreciate this on the inferior or the costal surface of the scapula, the internal surface of the scapula. So here is the internal surface of the scapula, also known as the costal surface of the subscapular. That's the surface of the scapula that is facing the back, the ribs from the back. So this muscle, the subscapularis, originates from the medial 2/3 of the costal surface of the scapula, right here, and then they go ahead to insert into the lesser tubercle of the humerus, where they further fuse with the shoulder capsule. So because the insertion of a muscle determines the kind of movement that such muscle confers on the joint around it. So this muscle, whenever it contracts, it pulls its point of insertion towards itself. And take note, the particular point of insertion determines the kind of movement it makes. So this time around, because it's inserting on the lesser tubercle of the humerus right here, it pulls this lesser tubercle of the humerus towards itself. All right, and don't forget, this is the right humerus, this is the right scapula. So you are looking at the right upper limb here, and you have this muscle. So it means the part that is facing you now is the anterior part of this scapula, the anterior view of this entire arrangement. So if this were to contract, you can expect that it's going to produce a medial rotation. Okay, a medial rotation, that is by moving this part of the humerus, this head of the humerus inward. Okay, it produces medial rotation and thereby conferring stability to the shoulder joint. This muscle, like the rest of the rotator cuff, is innervated by the subscapular nerves, which originate from C5 and C6. So here's the subscapularis. Next, that we'll be looking at from the rotator cuff is the supraspinatus. Like the name suggests, it is supra, that's above the spine. What spine now? The spine of the scapula. So this is the supraspinatus muscle. And this muscle, like you can guess, is originating from the medial two-thirds of the supraspinous fossa of the scapula, and it goes ahead across that furrow, that fossa, to insert on the upper facet of the greater tubercle of the humerus. It's of course innervated by C5, C6 as well, and then you can guess what the function of this muscle is. Okay, so for a muscle that comes to insert over the greater tubercle of the humerus, if it contracts, that means it pulls this point back to itself, right, back to it towards its point of origin, and that will produce what movement? Did I hear you guess? I'm sure you'll be happy to realize you guessed right if you actually mentioned abduction movement of the upper arm or of the humerus. So it initiates the abduction of the arm, and it also contributes towards the stability of the head of the humerus. That is supraspinatus. Next, so one of the ways to test the supraspinatus muscle is how much of arm abduction can be done against resistance. So if you go to the gym and you keep lifting the weight in the lateral direction, you are actually building up your supraspinatus amongst other muscles. Next is the infraspinatus, and you expect to find this, as the name implies, in the infraspinous fossa. So it originates from the medial two-thirds of the infraspinous fossa, and it goes ahead to insert on the central facet of the greater tubercle of the humerus. So what kind of movement do you expect from this? Certainly something slightly opposite to that which was conferred by the subscapularis, isn't it? So the subscapularis give a medial rotation of the humerus, and the infraspinatus will be giving a lateral rotation because it's going to be pulling this. So now this is the posterior view of this entire complex, and here is the anterior view of the same complex. So this is the right shoulder, and this is still the right shoulder looking at it from the back. So the infraspinatus will confer a lateral rotation movement on the humerus at the shoulder joint. And a way to test that is to produce an outward forearm movement against resistance. You can also keep the muscle in shape by giving it a resistance or a weight to counter in that regard. Next muscle, that's the last of the four rotator cuff muscles, is the teres minor. And the teres minor muscle, which is right here, is originating from the dorsal surface of the axillary border of the scapula. So it's right here, and it's originating. It's underneath. It's deep to the infraspinatus muscle. And so it goes from here to insert into the lowest facet of the greater tubercle of the humerus. Okay, so from having the same innervation from the axillary nerve, you'll see the teres minor muscle contributing to the lateral rotation as well. And then it also helps with some weak level of adduction, right? It contributes weakly towards adduction movement of the humerus, and it also contributes to stabilizing the humerus like the rest of the rotator cuff muscles do. Now, as an offshoot of that is the teres major muscle. So we looked at the teres minor muscle, which is right here a moment ago. Now is the teres major, which is not considered one of the rotator cuff muscles. So it originates from the dorsal surface of the inferior angle of the scapula. Okay, so the inferior angle of the scapula right here. So it originates from the dorsal surface of it, and it goes ahead, like you can see it move, to insert in the medial lip of the intertubercular sulcus of the humerus around here. So with this kind of arrangement, receiving a similar nerve supply from the subscapular nerve, you expect what kind of movement from a muscle that originates from the dorsal surface of the inferior angle of the scapula and going to insert into the medial lip of the intertubercular sulcus. What movement is that? Did I hear you guess? Okay, you're right if you mentioned abduction, right? So it will bring the humerus closer towards the side of the body. So that is the adduction movement. It also contributes towards medial rotation and also contributes towards extension of the arm. So a way to test this is to adduct the arm against resistance. You can try that out in the gym the next time you are strengthening your upper limb muscles. So the last of these muscles around the shoulder region is the deltoid muscle. It originates from the clavicle, from the acromion and the spine of the scapula. The acromion and the spine of the scapula, and as well the clavicle. So it goes ahead to insert in the deltoid tuberosity on the humerus. And I mean, that's why it's called that way. You can see the close association. And here you have the deltoid muscle over here. So it has a wide range of functions because it has different parts. So it has an anterior lip, the middle, and the posterior lip of it. So it contributes towards abduction. The deltoid is known with multipinnate fibers, so this contributes towards the abduction of the humerus, right? It also, the anterior fibers contribute towards flexion as well as medial rotation of the arm. So we are having a posterior view here, okay, of the shoulder and then the deltoid. While the posterior fibers here, as you can expect, would contribute towards extension and lateral rotation. So a good testing for the deltoid muscle arises during abduction of the arm against resistance, and it's also a common and safe area for intramuscular injection, so about 4 centimeters away from the acromion of the scapula. So the scapula has a number of anastomosis comprising of major arteries like the dorsal scapular artery, the suprascapular artery, the subscapular artery, and the circumflex scapular artery. So all of these arteries contribute towards this the anastomosis, and they help to ensure a collateral circulation whenever it so happens that the subclavian artery is obstructed. And then we can mention quickly about the capsule, the glenohumeral capsule, which attaches to the scapula around the labrum. So here is the labrum of the glenoid cavity. So this is where you have the glenohumeral capsule attaching from. You can see the capsule right here. So it attaches to the scapula around this capsule, around this labrum, and then it attaches as well to the humerus at the anatomical neck of the humerus. So thereby keeping further contributing towards the stability of that joint. So it attaches inferiorly, slightly lower at the surgical neck of the humerus as well. You know, the humerus has both the anatomical neck and the surgical neck. So its major attachment is at the anatomical neck, while it also attaches slightly lower to the surgical neck as well, which is usually susceptible to fractures. So there are a number of ligaments that come to play to contribute towards the stability of the shoulder joint. So we have a group of them that directly contribute towards stabilizing the glenohumeral joint. And this capsular ligament includes the superior glenohumeral ligament, which stabilizes the shoulder in the lower ranges of shoulder abduction so that you don't over abduct. So the ligament keeps that distance short and ensures that the ranges are within the safe one whenever the abduction is done. Also, you have the middle glenohumeral ligament, which helps to limit the external rotation whenever the arm is in a neutral position or is slightly abducted. So you see this running from the humerus down to the scapula, and you have the inferior glenohumeral ligament as well, which is the most important contributor towards stabilizing the glenohumeral joint. So it prevents anterior dislocation whenever the arm is raised or externally rotated. So it ensures that the head is not the head of the humerus is not dislocated out of the glenoid cavity. So you see it blocking up the head of the humerus in here. So the inferior glenohumeral ligament has an anterior and posterior band, as well as a slackened pouch in between those two bands. So we also have the spiral glenohumeral ligaments added to that picture. So we have some other supporting ligaments which contribute also, but indirectly, to the stability of uh, of the shoulder joint. So we have particularly the coracohumeral ligament, which runs from the coracoid process to the humerus here. So it connects the coracoid process while helping to support the weight of the upper limb and providing anterior stability, especially in a relaxed shoulder position. We also have the transverse humeral ligament, which is right here. So the transverse humeral ligament spans over the bicipital groove. Okay, it spans over the bicipital groove of the humerus while holding the long head of the biceps tendon in place. And you can see the long head of the biceps tendon right here. This way, it helps to maintain the alignment during shoulder movement. Um, without this contributory and synergistic um, effort by all these structures, the stability of the shoulder would have been far-fetched. So we have also the coracoacromial ligaments, which run from the coracoid process to the acromion of the same scapula. And this, as you can imagine, running from one part of the scapula to the other, so it just forms an arc. Okay, and this arc is quite protective. So it extends between the coracoid process and the acromion of the scapula. So this ligament limits the upward displacement of the head of the humerus. Alright, even though it does not directly attach to the humerus, but whenever there is a need for the head of the humerus to move up, perhaps during abduction or during elevation of the shoulder, the coracoacromial ligament serves as a protective arch to keep it within range and prevent it from going out of range. So we have a fourth category of ligaments that contributes to stabilizing the acromioclavicular joint, and this includes the acromioclavicular ligament, so which you have running between the acromion of the scapula and the lateral part of the clavicle. So this ligament reinforces the acromioclavicular joint by connecting the acromion to the clavicle. And we also have coracoclavicular ligaments, which connect uh, the clavicle to the coracoid process of the scapula. So amongst this is the trapezoid. So as you can see from the shape, the trapezoid ligament limits excessive scapular movement, while the conoid, named also because of its conical shape, it helps to restrict the elevation. It restricts the clavicle during elevation, and it also provides vertical stability to the acromioclavicular joint. So both of these ligaments run between the clavicle and the coracoid process of the scapula. They also contribute towards the stability of the shoulder joint. So the synovial membranes and bursae are also not left behind in ensuring the stability of the joint. So the synovial membrane generally, they line joint capsules, and they do the same in the shoulder joint. So they attach around the labrum, which we saw earlier and is still here, of the scapula in the glenoid cavity. So they form a sleeve around the biceps tendon as well. So we also have bursae, a number of bursae around that joint, and this includes the subscapularis bursa. The bursa is typically a small fluid-filled cavity or sac, a small fluid-filled sac that lines that has synovial lining in it. So they are usually found in areas that are prone to friction, particularly between bones and tendons or muscles. So that way they act as cushion, like they are doing here. So for this subscapular bursa or subscapularis bursa, it communicates with the joint through an anterior capsule gap around here. So we also have another one underneath the spine, known as the infraspinatus bursa, which is not labeled here, but it sometimes communicates with the joint posteriorly. So we also have the subacromial bursa, otherwise known as the subdeltoid bursa. So that is around here. So you have the deltoid over it. So this does not communicate with the joint, but it cushions the supraspinatus tendon that comes from the supraspinatus muscle. So this bursae helps to reduce the friction between these tendons and muscles and the joints where they are functioning. The stability of the shoulder joint therefore comes from a number of factors ranging from ligaments, some of which we have listed, capsular reinforcement, the glenoid labrum, which further deepens the glenoid cavity. If you look at the glenoid cavity in the scapula itself, you'll see that it's a very small space. But with the attachment of the labrum, it increases the surface area, which is a further addition to ensure further stability. So you have the labrum around here. So here is the glenoid cavity, and then the labrum deepens the fossa. Okay, before we now have the capsule further encircling everything. So here was the biceps tendon that we saw earlier. And then you have a number of other structures. So the supraspinatus tendon is right here, and then the deltoid bursa, you can appreciate that better here. The infraspinatus tendon is here, the teres minor tendon is here, the subscapularis tendon from the subscapularis muscle is right here. So we also have the rotator cuff muscles ensuring the stability from the muscle angle, right? And then you have the coracoacromial arc, which is formed by the coracoacromial ligament, which prevents upward displacement of the humeral head, as we mentioned earlier. So this makes us appreciate the number of movements that could happen in the shoulder joint and how this movement is kept within stability range. And this ranges from abduction to rotation to abduction to circumduction, amongst others. Now, while this movement is going on, it's important to note that there are normal ranges as well as excessive, and there are ranges that could be transcended, which would result into some hurt, or some ranges that may not be possible whenever there is paralysis in the nerves that innervate some muscles. So the abduction is normally up to 120 degrees at the shoulder joint. Okay. So to make that up to 180, then there would have been a complementary rotation of the scapula. The scapula would have rotated to add the remaining 60 degrees that would help you to achieve 180 abduction of the shoulder joint or of the arm at the shoulder joint. So it's also important to understand, that the humeral rotation allows the head to maintain articulation with the glenoid fossa during this movement. There is also the concept of the scapulohumeral rhythm, which makes us understand that for every 2 inches of movement uh, by the humerus, there is a complementary 1 inch of movement by the scapula to ensure that the eventual movement takes place. So this is the scapulohumeral rhythm. So the scapula and the humerus, they move in a 1:2 ratio. So 1:2 ratio, the 1 is for the scapula, and then the humerus has the 2. So for every 1 movement made by the scapula, 2 of them have been made by the humerus around the shoulder joint. So when the arm is abducted at 180 degrees, 60 degrees occurs by rotation of the scapula, and that's why the 120 is what is done by the humerus. And when these complement together, you can have the 180 full abduction of the shoulder. So there are a number of injuries that are common to the shoulder. We'll mention just a few of them. So dislocation is very common. So the shoulder is very vulnerable to dislocation, particularly due to the laxity and small glenoid cavity. So, and this is typically occurring in the anterior direction whenever the dislocation is to happen. So like you have here. So, and whenever this happens, the axillary nerve gets injured. So it's located directly below the joint capsule, and may be damaged during the dislocation. So the axillary nerve is very much in danger. Also, the rotator cuff muscles, they can be lesioned. Okay, they can be lesioned, and this commonly affects the supraspinatus, especially the tendon of the supraspinatus, due to its impingement under the coracoacromial arch. So whenever this muscle, the tendon of this muscle is inflamed, then it gives a painful arc during abduction. And usually for a person that has injury to the supraspinatus, which is one of the muscles in the rotator cuff that we discussed earlier, the range of movement is usually between 60 and 120. Usually they are not able to go beyond 120 whenever they are abducting the upper arm, or whenever they are abducting the upper limb at the shoulder joint. So for a person that has supraspinatus tendinitis, so, and it's called, there is a potential rupture that could happen in further advanced cases. So that brings us to the conclusion of some of our talks on the shoulder. Now is the back and the vertebral column. And we know that the vertebral column has the cervical, the thoracic, the lumbar, the sacral, and the coccygeal parts. Generally, the back and this vertebral column provide support and protection to the spinal cord. It supports the posture of an individual, it protects the spinal cord, and it also facilitates the movement. So you have the different segments of the backbone, otherwise known as the spine, right here. So here is a side view of two of the vertebrae, and you can see the spinal nerve coming out of the intervertebral foramen right here. You have a number of facets which where the vertebra underneath articulates with the vertebra above. You have the intervertebral disc, which serves as a cushion to prevent friction between the vertebral bodies. So here is, we'll come back to the anatomical part of vertebrae in a while. You can see a ligament here. So here is a side view, the lateral view, and here is the superior view of the same vertebra. So clearly, within the vertebral foramen, you can see the spinal cord right in here, and then the spinal nerve coming out on the side, and we can see the articular facets around here. Okay, we'll appreciate this further in this slide now. So typically, each vertebra has a body and then it has an arc. So every other part of the vertebra, aside the body, contributes to the part that we call the arc of that vertebra. So here is the vertebral body, here is the vertebral arc. Now to go into further details, the vertebral arc now has subparts. So here is the spine, the spinous process of the vertebra, and this part is the lamina of the vertebra. Here is the superior articular process of this particular vertebra. So there are inferior articular processes too, which are not really visible. They are usually around here. And then you have this lateral part known as the transverse processes of the vertebra. And here are the pedicles of the vertebra. So here is the foramen, okay, of the vertebra. So the part includes the vertebral body, which is the load-bearing part, which is progressively larger in lower vertebrae. So the topmost part is the lightest, and I mean the vertebral bodies of the cervical vertebrae, for example, are not as large as, so the lower you go, the the bigger the vertebral bodies become, because that is where the weight of the individual starts to concentrate. And then you have the vertebral arch, which encloses the spinal cord, and then the processes like we have listed. So you have the spinous process for muscle and ligament attachment. You have the transverse process also, which leverage which also serve as a leverage for muscular attachment. You have the articular processes, which forms facets, joints for vertebral articulation. So here is a typical vertebra. So here is the superior view of a vertebra, where you can appreciate some of the labelings we just talked about. So the body is right here. Here is a facet for the head of a rib. You have superior articular facet, that's for the attachment to for the articulation of this particular vertebra with the superior vertebra. You can see the spinal cord here. The vertebral foramen is the space that the spinal cord occupies at that level. You have the spinous process here. And yeah, so here are transverse processes, which you can appreciate in this lateral view, or yeah, you may want to call it posterolateral view of these three vertebrae as well, where this region is going to be the anterior and this part will be the posterior. So you can see the spinal cord again. You can see this superior articular process. You can see this facet for attachment of the adjacent rib. You can see the inferior articular process right here, the spinous process. The body is here. The pedicle is right here. The lamina is here, which connects the arc to the spine, and then you have the intervertebral disc right here, and the transverse process again. So here is the left posterolateral view of articulated vertebrae. And the vertebrae in each region of the 5 regions have peculiarities which make them stand out anatomically, right? So here are cervical vertebrae, for example, and here are thoracic vertebrae, and you have lumbar vertebrae around here, and the and then the sacral vertebrae around here. So here's, pardon me, I mean, here are the cervical vertebrae. So particularly the atlas and the axis are here. And then the rest of the cervical vertebrae, you find them here. And then you have the thoracic vertebrae right here. And this is the lumbar vertebra. So a peculiarity of so you can appreciate the transverse process of the atlas here. This is the axis. So the atlas is the first cervical vertebra, while the axis is the second cervical vertebra. So the axis is the one with the odontoid process right here, which fits into this point. Okay, so you have the anterior arc, you have the posterior arc, you have the transverse process, you have the spinous process, which is not that prominent in both vertebrae, but you still have it slightly more prominent in the second cervical vertebra, known as the axis. You have the transverse process, you have the facet on the superior articular process with which it attaches to the atlas above it, and you have the body of the vertebra here. For the rest of the cervical vertebrae, you can see these facets as well, and the superior articular process, the spinous process, which is now lengthening more, and you have the transverse process, the body. So here is the right lateral view, and in this thoracic vertebrae, you can see the spinous process, the facets, the body, yeah, and the rest of that. And you also have, so you'll see these shapes And progressively, the body keeps increasing in size as it goes down, and this takes us to the regional characteristics of these different regions. So for the cervical vertebrae, you will notice that the bodies are quite small. You have this transverse foramen for vertebral artery, okay, and you have the bifid spinous processes too. Then in the thoracic vertebrae, the bodies were heart-shaped, and they have costal facets because that's where you have ribs coming from arising from the vertebrae, the thoracic vertebrae, to go and uh, connect with the sternum through the costal chondral cartilages. And you have the costal facets, you have the long spinous processes in the thoracic vertebrae, longer than what you have in the rest of the cervical vertebrae. Okay, and then you have, for the lumbar vertebrae, they have large kidney-shaped bodies. They were heart-shaped in the thoracic vertebrae, but they are kidney-shaped and larger in the lumbar region, and they have thicker spinous processes. Okay. For the thoracic, they are characterized with their length. They are longer. You can see the spinous processes are much longer. But in the lumbar region, they are much shorter and then thicker. Thick spinous processes, and it's the strongest region where you have weight bearing of the body. And then the sacral and coccygeal vertebrae, they are fused structures that support pelvic organs. So, one of the things to take note of as a variation in the vertebrae is what we call lumbarization and sacralization. So, a normal vertebral arrangement is to have 5 lumbar vertebrae, L1 to L5, and then you have the sacral vertebrae continuing from there. But it could happen that what should have been the first sacral vertebra takes up the anatomical characteristics of the lumbar vertebra, and that way it becomes the 6th lumbar vertebra. That means that that vertebra has been lumbarized. It would have normally been a sacral vertebra, but it has become a lumbar vertebra. So that is lumbarization of sacral vertebra. So that's the failure of the S1 to fuse with the rest of the sacrum. So that is lumbarization. And the flip side as well is that the sacral vertebrae in this case, are turning one of the last of the lumbar vertebrae into their own. And that way, when you have fusion of the transverse processes of the L5 with the rest of the sacrum, then that is sacralization of the 5th lumbar vertebra. So that makes it the first sacral vertebra actually. So that's so in that case, that such individual will have just 4 lumbar vertebrae, L1 to L4, and then 6 sacral vertebrae. In the case of lumbarization, there will be 6 lumbar vertebrae and 4 sacral vertebrae. So here is a further description of what I've just explained. So lumbarization is a non-fused first sacral vertebra appearing as an additional lumbar vertebra, while sacralization is a fusion of the 5th lumbar vertebra with the sacrum. So the clinical implication of this is usually low back pain and altered mechanics of the spine. Also, vertebral column joints. So factors that contribute to these include the intervertebral discs, which we have here. So the annulus fibrous and the nucleus pulpus, which make up this disc. So they absorb shock and allow flexibility. So flexion will be bending forward. So during flexion of an individual, when the person bends forward, so you have this kind of movement, and it increases the intervertebral space, and then the arc of the vertebra moves upward while the vertebral body goes down. But the opposite is what happens during extension. So during flexion, The vertebral disc, the anterior part of the vertebral disc is slightly compressed, but so long as the vertebral disc is still intervertebral disc is still intact, it absorbs that movement and ensures that both vertebral bodies do not touch each other despite that flexion movement. While the posterior part of that intervertebral disc is what gets compressed in the case of extension movement when you bend your back backward. So we also have the facets, so which are a kind of zygapophyseal joints. So it's a synovial joint between the vertebral arches, which allows gliding movement. And we have ligaments. We have anterior ligaments and we have posterior ligaments. So here is the anterior ligament, anterior longitudinal ligament of the vertebra, and these are the posterior longitudinal ligaments of the vertebra. So here is ligamentum flavum, which is an elastic uh, uh, a component that connects the laminae of the adjacent vertebrae. So here is the lamina that the ligamentum flavum is connecting, and here is the interspinal ligament. Okay, and we also have the supraspinous ligament, which is the part of the ligament that overlies the spinous processes. So it runs along the tips of the spinous processes. That's why it's called the supraspinous ligament. So as for the interspinal ligament, you have it between the spinous processes. And yeah, so the anterior ligament and the posterior ligament prevent hyperflexion and hyperextension. The anterior spine longitudinal ligament will prevent hyperextension, while the longitudinal ligament will prevent hyperflexion. So here is, we've come this far, and a quick stop to quickly check how far you're following. You know how we do this. You have your flashcards already by now. So I'll be asking the question about which vertebral feature is unique to the thoracic vertebrae based on the discussions that we have had. Is it the bifid spinals? Is it kidney-shaped body? Is it costal facet? Is it transverse foramina? Which vertebral feature is unique to the thoracic vertebra? Okay, 1, 2, go. What card have you flashed? What card have you flashed? So if you flashed any card other than the yellow card, then you're wrong, because the yellow card takes the day in this case. So it's only the thoracic vertebrae that have costal facet for the attachment of what? The ribs. So different kind of movements that could happen and their degrees is I found this table quite useful to summarize that. So in the cervical vertebra, you could have some level of flexion, you could have extension of the neck, you could have lateral flexion, and then you could have rotation of the neck. So it is quite extensive in all directions. Okay? As for the thorax, you could have some level of rotation. You could have rotation, rotation of the thorax, as when you are doing some exercise, and then you could have flexion of the thorax, and you could also have extension of the thoracic vertebrae, and then you have lateral flexion as in bending sidewards. So the level of rotation is quite moderate, and then the level of flexion and extension is quite limited in the chest itself, unlike in the neck. While for the lumbar, you have some flexion, some extension, and some lateral flexion as well. So, however, it's quite minimal when it comes to rotation. And then for sacrococcygeal region, the sacrum and the coccyx, it's not applicable. They don't literally move. So there's no significant movement there because the bones are fused. Curvatures now. So the primary curvatures you have at the thoracic and the sacral region, and these curvatures develop during fetal period. So these are the primary curvatures at the thorax and at the sacrum. Secondarily, you could have cervical curvatures when an infant lifts the head, and you could have lumbar curvatures when infants begin to walk. Okay, this happens much later. But then abnormalities could also arise in this movement. So when you have excessive thoracic curvature, sorry, I forgot to add the picture. I thought I did at some point. So when you have abnormal curvature at the thoracic region, so that is known as kyphosis. Sorry, I'm not able to go to the previous slide, so but you can replay the video to watch that part. So abnormal curvature at the thoracic region is known as kyphosis, and when you have and it's an anterior posterior displacement, so excessive curvature of the thoracic vertebra is known as kyphosis. Excessive curvature of the lumbar vertebra is known as lordosis. While when you have the curvature on the lateral, so abnormal lateral curvature from the thoracic down to the lumbar is known as scoliosis. So here is where we stop quickly again to ask a question, and this time around I'll be asking which region has the greatest range of rotation. Which region? Okay. Which card will you be flashing this time around? I hope you've not flashed any card other than the blue, because we know that the cervical region has the greatest range of rotation. Okay, the vertebral column vasculature is chiefly reliant on the segmental arteries from the aorta. So here is the aorta, so the arc of the aorta, ascending the arc and then the descending. So from the from this aorta, from these arteries, you have segmental arteries, so which run along the vertebrae, including the vertebral, the intercostal arteries, and then the lumbar arteries. And then venous drainage also is similar, particularly through the internal and external vertebral venous plexuses, which end up draining back into the segmental arteries at different segments, and eventually they go back to empty into the vena cava. Yeah, so that's what I've illustrated here again. Nerves as well. So you have cervical nerves, you have thoracic nerves, lumbar nerves, and sacral and coccygeal nerves. So do not forget that the conus medullaris is where the spinal cord ends within the vertebral column, and then you have some fibers emanating from this, so known as the cauda equina, okay, which terminated as the phylum terminale. So you have so as soon as you have a spinal cord emerge from the foramen magnum of the brain into the cervical vertebral canal, so there you start having the cervical plexus of nerves emanating as the cervical spinal nerves. Then these, along with the T1, contribute towards the formation of the brachial plexus at the axillary region, and then you have the thoracic spinal nerves. Then there is an enlargement when the spinal cord gets to the lumbar region, and yeah. So you have 31 pairs of spinal nerves in total, 8 of them cervical, okay, and then you have 12 of them thoracic. Then we have 5 of them, 5 pairs of lumbar, and 5 sacral pairs, and then you have the cauda equina. So here's the spinal cord with its different meningeal layers, the pia mater, the arachnoid, and the dura mater, just like we have in the brain as well. So the spinal nerves exit via the intervertebral foramina, which we have seen in previous pictures, as mixed nerves. So carrying both sensory, which is the dorsal root, and then the motor, which is the ventral root fibers. And then the regional functions include at the cervical, these nerves You find them at the supplying the neck, the shoulder, and the upper limbs. Then the thoracic muscles supply the thoracic nerves, supply the chest and the abdomen. And then the lumbar and sacral nerves contribute towards the innervation of the lower limbs, the pelvis, and the trunk. So recurrent meningeal nerves, also known as the sinovertebral nerve, it branches from the spinal nerves just outside the intervertebral foramen, and what it does, it goes back in after I hope the picture is somewhere here. Yeah, so it goes back in, it re-enters the vertebral canal to innervate the meninges, this meninges you have here. So posterior longitudinal ligaments, the periosteum, and the outer layers of the intervertebral disc all get innervated by this recurrent meningeal nerve. It's very crucial for pain sensation in the vertebral column. Okay, and it's particularly associated with disc and ligament injuries or degeneration. So whenever there is a degeneration in any of these, the recurrent laryngeal, the recurrent meningeal nerves helps to radiate this sensation. We also have autonomic connections, the sympathetic through the sympathetic and parasympathetic chains. So whenever there is a nerve compression, as in disc herniation, um, this can lead to pain and serious loss of function, motor functions and motor dysfunctions. So whenever you have the herniation, if the disc through a tear in the outer layers, or the outer layers of the disc, whenever there is a tear there, so the content of the disc will end up herniating, and this reduces the integrity of the intervertebral disc, so thereby leading to a number of painful sensations, because the disc is no longer able to perform its function of preventing frictions, and then you end up having the spinal cord getting compressed. Okay, and then the recurrent laryngeal nerve also gets affected by this. So we have a number of muscles in the back. This includes the extrinsic muscle, the intrinsic muscles. So the extrinsic muscle has superficial layers, and it also has intermediate layers. So the superficial component of the extrinsic muscles are these five major muscles, starting with the trapezius, which you have right here, and then the latissimus dorsi. Okay, and then you have the rhomboid muscles, both the major, which is this, and then the minor rhomboid muscle. And here is the levator scapulae muscle. So these are the superficial muscles. So as for the intermediate muscles, these are majorly the serratus posterior superior, which you have here, serratus posterior superior, and then the serratus posterior inferior. Then the intrinsic muscles are quite more interesting. So you have them across all around here. So you have the semispinalis. So you can see them along the neck region. You have them at the back. You have them just at the base of the head as well. So these intrinsic muscles, you also have the superficial layer of them, which includes the splenius muscles like the capitis and the cervices. So the capitis and the cervices. So these are the suboccipital muscles which help to rotate and extend the neck. Okay, so we also have the intermediate ones, like known as the erector spinae. So this includes the iliocostalis, the longissimus muscle, and then the spinalis, which is directly opposed to the vertebrae. So these are the primary extensors of the spine. And then you have the deeper ones, deeper muscles like the semispinalis, the multifidus. So these are considered the transversus spinalis group. Okay, so these muscles help to rotate the spine as well, and then they stabilize the spine. So as we move gradually towards the conclusion of this class, it's important to appreciate the surface anatomy of the back muscles. So you have a number of landmarks that you can appreciate on the surface, especially when you have the arm abducted this way. So you would appreciate the vertebral prominences, okay, particularly of the C7 at this point. Okay. So here is the acromion. You can appreciate the shape this way. So here is the acromion, the acromial process of the scapula. Then the spine of the scapula is here. Then the infraspinatus. So normally you would have wanted to appreciate the supraspinatus somewhere in between here. Uh, so here is the spine of the scapula, and here is the infraspinatus right here. So here's the vertebral border of the scapula, and the inferior angle of the scapula appreciated here. So here is the scapula, the vertebral border, and here is the inferior angle of the scapula. So you have a furrow. So the furrow over the spinous process of the thoracic vertebrae is readily appreciable. And then the erector spinae muscles, which we mentioned earlier, not long ago, you have the iliac crest around here. So here is the latissimus dorsi muscle, and you have the teres major muscle right here. Here's the trapezius muscle, and the deltoid is here. There's a posterior fiber, intermediate, and then the anterior over there. The biceps right here, the triceps brachii muscle, the lateral head of it is here, and then the long head of the triceps brachii is here. So this is pretty interesting, especially if you are not an asthenic individual. So if you are well built, and you should be able to appreciate this. Yeah, so you can palpate a number of these muscles for clinical examination. The suboccipital, so this slide should have come slightly before the previous one. So while we were discussing the muscles, so these are the suboccipital muscles at a bigger, as a more enlarged view. So rectus capitis major, the rectus capitis posterior minor. So obliquus capitis superior, and then the obliquus capitis inferior, and these are the deep back muscles. So these muscles help to extend the head and rotate the head. They also stabilize the atlanto-occipital and atlanto-axial joints. That's the joint you have between the atlas and the axis, as well as the joint you have between the atlas and the occipital bone of the skull. So it's time to check again before we conclude how far we are coming along. So which muscle is primarily responsible for the extension of the back? Can I see your card? 1, 2, go. Is it the trapezius, the rectus spinae, the serratus posterior, or the rotatoris? Which card have you flipped? Congratulations if you flipped the green card, because here it's the erector spinae muscle that contributes most amongst these muscles towards the extension of the back. So the contents you have in the vertebral canal is the spinal cord, and it's yeah, the spinal cord. So it extends from the base of the foramen magnum down to the first or second lumbar vertebral point in adults. So that's where you have the conus medullaris. Then you have the enlargement. You have the enlargement. Um, so at the cervical and the lumbar part, for limb innervation. And you also have distal structures like the conus medullaris, like I mentioned earlier, and the cauda equina. So the spinal nerves and their roots originate from the spinal cord. So here is the gray matter content of the central spinal cord. You have the white matter superficially on the exterior, and you have the dorsal horns and then the ventral horns of the spinal cord. So from the ventral horn, you have the ventral roots coming out, and then you have the dorsal roots coming out from the back of the spinal cord. So here is the anterior, and then here is the posterior of the spinal cord. Here is a cross section. So this part will be the posterior, while this part will be the anterior. So the front of it is the ventral. So the ventral roots comes out of it, and then the dorsal root comes out at the back and has a quick stop at the ganglion here before meeting up here. So at this point, it is referred to as a spinal nerve. Before then, you have some decussations. So we then have the dorsal ramus and the ventral ramus arising from the spinal nerve. I have some white and gray rami as well. So the dorsal root is responsible for sensory, for conducting, bringing sensations into the spinal cord, while the ventral root gives out the motor innervation, the motor responses. So the sensory impulses are received through the dorsal root, because that's the sensory, while the motor responses are affected through the ventral root, which contains the motor fibers. So common nerve root compression due to herniated disc in cervical and lumbar regions obtained is quite relevant to mention at this point. Yeah, the meninges as well, like we said, just like you have in the brain, you have the pia mater directly opposed to the spinal cord substance. Then you have the arachnoid matter just after that, out of that, and then you have the dura matter, which is very tough. That's the outermost layer. The arachnoid is the middle layer with subarachnoid space. Then you have the pia mater, which is the innermost delicate layer that adheres tightly to the spinal cord. So we mentioned already the posterior roots as the dorsal roots, the ventral roots as the anterior roots. The spinal nerve is formed after these two unite. Here is the subarachnoid cavity. So you have the dura mater on the exterior, you have the arachnoid mater in the middle, and then you have the pia right deep. So yeah, for us to do a lumbar puncture, the L3 to L4 level is usually a safe site for lumbar puncture in order to obtain some cerebrospinal fluid, some CSF for biopsy. So to obtain some lumbar biopsies is usually done at the L3, L4 level. So vasculature of the spinal cord also comprises of the anterior spinal artery and then the paired posterior spinal arteries. So the anterior spinal artery is usually single, while the posterior spinal arteries are usually both, two of them are usually paired. And then the veins, you have a spinal venous plexus, which serve as route for venous return from the blood. So one of our last questions is, at what vertebral level does the adult spinal cord typically terminate? At what vertebral level? You have your cards. 1, 2, go. At what level? Did you say L3? That's not correct. Did you say S1? That's not correct. Congratulations if you flashed your green cards, because the correct answer is L1 to L2. So, clinical correlations, we mentioned disc herniation, spinal disc herniation, which is common, especially in the lumbar region. Pressure, it's because it results into a pressure on the nerve roots, which leads to a radicular pain. We also have what is called spinal stenosis, which is a narrowing of the vertebral canal. Oh, good. Here is where the picture of the lordosis kyphosis and scoliosis is. So when you have a narrowing of the vertebral canal, that's often referred to as stenosis, and re- it results into compression of the spinal cord and the nerve roots. So scoliosis and kyphosis, they are abnormal example of abnormal curvatures, as you can see here. So here is kyphosis, abnormal curvature of the thoracic vertebrae, and here is lordosis, abnormal posterior curvature of the lumbar vertebrae. And if the abnormality is sideways, that is scoliosis. And there are different types of scoliosis as well, because scoliosis is a lateral abnormality in curvature. So the scoliosis could be at the thoracic point, it could be lumbar scoliosis, it could be thoracolumbar scoliosis, and it could be a combination of all of these. So that will be combined scoliosis. So muscle strain is also common in the intrinsic back muscles, especially during lifting of this lifting of items or a sudden movement. So you get to recalibrate and then start feeling. So it is a nice journey so far, and it's now time to summarize that we understand now that we understand better about the vertebrae and the vertebral column, the structure, the function, and the regional characteristics. We've also talked about the distinction between the extrinsic and intrinsic back muscles, as well as their functions. We've also gone through the content of the vertebral canal, to include the vertebral cord, the meninges, and the vasculatures. And then the movements around the curvatures, we've also gone through that. We've understood the typical range of movements of motion and alignment that are possible. So on this note, I want to encourage you to consult a number of major gross anatomy textbooks that are at your disposal, and I wish you all the very best as you read this up, and I hope you've had a nice time in this particular class. So I wish you all the best, and I hope to see you at the next class. Feel free to drop your questions in the comment sections or you send them to me directly. All the best and bye for now.